Thank you so much. Can everybody hear me? All is good, and you can see my screen? Okay, perfect. Didn't want to get too far into this before I made sure that everybody could do that. Just as a general introduction, my name is Amy Delliger Page. I'm a professor of sociology at Appalachian State University, which is in North Carolina in the United States. My background is largely in sexual violence and sexual offenders and policy, but about 5 years ago, I switched to studying end-of-life doulas and trying to learn more about end-of-life doula care. I'll just say first, as a part of this introduction, thank you so much to the End-of-Life Doula International Research Group for hosting this symposium, continuing this opportunity to sort of hear from and learn from other researchers. This is kind of a small field, and so it's nice to have the opportunity to get together. And thank you so much for all the work the organizing committee has done on this. I will also add to Marion's thanks to the folks who are joining from all over the globe and managing a variety of time zones and all the difficulties that come with that. So thank you all for making that space for us. So I want to start this. Oops, my screen is not moving. There we go. All right, I want to start this presentation also by just saying it echoes a lot of what Marion shared from the Delphi study. So I think that's kind of interesting. Given that we can't, hopefully this will just kind of echo those results from a different set of doulas, but I think it serves as sort of confirmation that these are priorities and challenges and things that we need to study further. So the information for this presentation sort of derives from 2 studies as well as conversations and trainings that I've participated in, some workshops that I was part of, and just conversations with leaders in the field. The first study was a multi-method study that used an online survey and 39 follow-up qualitative interviews with doulas who were registered with INELDA, the International End-of-Life Doula Association that's based primarily in the US. And then a qualitative study that I'm in the process of wrapping up with 15 queer identified doulas who serve LGBTQ plus communities in both the United States and in Canada. So I want to kind of frame some of these challenges, and I hate that challenges is such a negative word, but maybe we should call this further points of discussion and areas that need our attention. So the framework for this talk will be really around the lack of knowledge about end-of-life doulas and their care, the business challenges and the access to care issues that come from part of that lack of knowledge, some of the professionalization issues and debates that Marion alluded to as well. That kind of stems from differences in education, certification, and the breadth of services that doulas provide. And then the issue of cultural competence, which I think has always been part of the conversation and is really important and vital, but more recently, particularly for those in the United States, has really sort of taken a front seat in a way that we were hoping was not going to be a continued case. So first, to talk a little bit about the lack of knowledge. Most of the challenges that I'm going to talk about really kind of stem from this lack of knowledge, and it's both the lack of knowledge kind of within the general public, but also among medical practitioners. And all of the things that I'm really going to talk about today are so interwoven that sometimes it's kind of difficult to tease these apart. But for the lack of knowledge, it comes down to people maybe not seeking out the services they want and that they need because they don't know who to contact or how to access those services. And they face a barrier of medical practitioners not having a lot of education and information about these available services. And you can't refer someone to services that you don't know about. I think in the United States in particular, this gets compounded by the fact that people are really uncomfortable talking about death and dying. It's viewed as really morbid as a topic of conversation rather than contributing to how we continue to live our lives. We have a very medicalized view of death, and so death is seen as a failure within our own progress in life. When people are referred to doula services, if they are referred, it's often very late in their progress sometimes. And so that can really limit the services that a doula can provide at that point and the work that can be done with that individual and their family. In addition, there are structural barriers that can happen, again, stemming from some of this lack of knowledge and understanding. So when doulas are working within these more structured and institutionalized environments, this lack of knowledge about the fact that doulas can often be a bridge between or within the circle of care and with the dying person. Instead, they spend a lot of time trying to gain the trust and the support of some of the medical staff and other staff within the institution, rather than them having a better understanding from the outset of what the roles of doulas are, how they are there primarily to be this bridge between medical personnel and the individual and the rest of their circle of care. And then sometimes if they're not already part of these established teams, which sometimes in larger cities, they are part of these teams, but if they aren't, they spend time trying to gain a better understanding of what the bureaucratic operation is within that particular setting and what the culture is within that particular setting. And that can inhibit, and that time it takes to sort of learn that can inhibit that communication and some of the collaboration between the medical team and end-of-life doulas. So Carol discussed this a little bit in her quote where she said, and so understanding the rules of what a doula can do and what a hospice nurse can do is confusing for people, and to gain people's trust to allow them to feel comfortable, I think that's one of the challenges that we face. Kathy added to this by saying, fitting in the existing system, that's the biggest challenge. The doula comes in and has to fit within the hospice process, which is a process. It's very carefully regulated and delineated. Another aspect that a lot of the doulas talked about are business challenges. And these business challenges are kind of far ranging, but we do operate within these capitalist structures. And so sometimes they talked about the fact that establishing a business model and a pay or fee structure was really challenging because people aren't really well versed in, again, finding doulas, understanding that they have to pay out of pocket for those services because currently, at least in Canada and the US, these services aren't covered under insurance. And so that can limit access. Some doulas will work on a sliding scale so that they can increase access, particularly to low income and also other marginalized communities. But really that comes down to whether they have another source of income, either through another occupation, whether they can offset the cost of services through education efforts that they might do, or whether they have whether they have a partner or someone else who can contribute to sort of the household finances. So that can limit their flexibility on allowing for having a sliding scale. So Holly said, honestly, not getting paid. And you know what I mean? I'm not looking for a lot of money, but I am looking to be paid or recognized for the work that we do. Christine added to this by saying, well, I mean, my challenge is not around doing the work when I'm doing the work. My challenge is around understanding how to do it responsibly as a business. It's the how to be a business person is the part that's challenging. I can do the work all day long. That's not the problem. The problem is how to manage it as a for-profit business. So related to this, establishing the fee structure, there's a history of devaluing this type of labor, primarily because in the past, it's been done mostly by women, particularly women of color. or it's been part of mutual aid that's offered as part of a community. So I think about what happened with the AIDS crisis and the queer community serving pretty much as doulas for one another as a form of mutual aid. So because of this, individuals can find it really difficult to establish an appropriate fee structure and charge for the services that they provide, because they've internalized some of this larger capitalist infrastructure and belief system that devalues that type of work. Similarly, other people may also devalue this work for a lot of the same reasons. And so establishing a fee structure that makes sense both for their own financial success and business success, but that also reflects the level of work and education and training that goes into their work, and getting an appropriate fee structure can be challenging. So Charlie summed up sort of all of these business-related challenges, noting, so you had asked about how people find me, and they find me through my website, and I make it clear that I'm willing to work on a very big sliding scale with people who face financial hardship, particularly to us LGBTQIA+ communities. But I'm predominantly still hired by upper middle class white people who may be or are likely to be at least middle-aged, so they have the financial stability that's sometimes associated with midlife. Chances are you have some kind of financial stability, and you can use that to hire a doula. It's an unregulated profession here in Canada, so yeah, like I don't qualify for any insurance reimbursement for my services. And in fact, I don't make a huge income from this work. So Charlie alluded to this lack of access to care, and that can sort of stem from a couple of different places as well. There could be monetary access to care that is limited, since people do have to pay out of pocket for services, but it can also be related to cultural competence and geography. I think about rural communities and folks who may not have a wide net of doulas who are available in that specific area, who are culturally competent to serve different faith communities, different cultural backgrounds, and different identity-based communities. And even if someone might be able to access services, say from a larger area through Zoom, which is great now that we are more accustomed to working in this sort of online environment, that doesn't provide access to services that are in person and would be holding space and sitting visual, these things like that. So it still limits those aspects. In terms of professionalization, as Miriam mentioned, this is a big source of discussion and concern, I think, among end-of-life doulas. And I'm wondering if part of the reason that it was sort of so diverse is because there's so much contained within the idea of professionalization and this concept. And so I wanted to sort of break out some of these pieces. One current concern around professionalization is the education. So right now, education in terms of training and content of how doulas are trained is huge. Hugely variable. So there are trainings that are simply 2 or 3 hours long that are online that you can watch at your own pace, while others average 36 to 40 hours and have pre-training work and regular follow-ups. Some add on a certification process where there's supervision of care with actual dying persons, like following up over a period of time and providing feedback and supervision during that process. And so some doulas want to really address some of these discrepancies and create sort of a vetting process about how much training is appropriate. And some doulas also voiced concerns about, even if you are trained, that doesn't necessarily mean you're ready to just go off and be a doula. That there's a lot of other important things that come with actual doula work that may need to still be supervised, right? Many of them also worry about the fact that as this work might become more regulated, it could lead doula work away from its original mission, similar to what happened with hospice care. So Tim said, because it's unregulated, it's not something that's payable through insurance or anything. And that's been a point of conversation for us in some of our gatherings, and even in the course that I took on death doula practices. I guess there's kind of two sides to this. It's something that's hard to really put a price tag on, actually, because it's such a sacred practice. So I almost don't want to see it regulated, but I would love to see it more mainstream, more widely known about, and accepted through different parts of our society. Rain added to this by saying, I understand why it would be great if we have insurance, but a lot of people I want to work with and who need my care don't have personal insurance anyways. Massage therapy here is not covered by our provincial health care. It's only covered by personal insurance you would get from your job. A lot of people still don't have that, depending on the kind of job you have. A lot of marginalized people don't have that. If it did become part of an insurance plan, then my prices would go up. And then Zena added to that, so I think there are a lot of questions, not just about professionalization, but who gets to call themselves a doula? Who gets to charge money for being a doula in a context where we're seeing not just increasing professionalization, but commercialization and monetization of the practice in ways that I don't necessarily think are about shifting the system in anti-oppressive ways. So again, some of this comes back to the services offered as well. There are a lot of concerns and discussions around what gets to count as legitimate or what's seen as legitimate services. And then there's also wide variation in some of the services that doulas offer. So some doulas focus primarily on what I call support services for dying persons, and this centers around helping with legacy work, advocacy, guided imagery, music therapy, meditative practices, Reiki and other types of massage therapy, healing crystals, and others. While other doulas tend to focus more on the logistic services like education through death cafes and things like that, creating a death plan, pre-planning, helping with advanced directives and other types of paperwork. And then others focus more on caregiver support services like post-death bereavement and grief support. And then other doulas do this full range of support, logistic, and caregiver support services. So there's a lot of variation in what gets included within these services. And finally, I'll just mention cultural competence remains an issue. As Marian shared, the majority of end-of-life doulas are white. They're middle-class women, and about half of them have some kind of prior background in healthcare. Even when you have culturally competent doulas and they can be connected with dying persons in their circle of care, they still have to interact within these medical systems and healthcare institutions that are often discriminatory, or at least carry the weight of prior and historical discrimination. And then allyship can still be an issue as well. While some are happy to work with someone who may not share identity but shares allyship, it can't replace lived experiences. And for some folks, having access to someone who shares those lived experiences as they're having experiencing this vulnerable time in their lives and want someone who can ensure that they have agency in the process, this can become really important. So Michelle shared, a big part of it is the people around the dying person. If someone who is trans dies and they have family members who are not supportive, or it doesn't even necessarily need to be people that know them that aren't supportive. It could be people working in the hospice or the hospital that are making assumptions based on their body as they're taking care of their body after death or in the process when they're not able to communicate verbally. Those are the things that I think people are having to deal with. And Charlie added to that saying, like, the paperwork for advanced care planning isn't inclusive of my family structure or kin structure. And then Zena sort of highlighted all of these many challenges that I've discussed by saying systemic discrimination is real. people in the LGBTQ plus community are coming into their end of life experiences with often lifetimes of accumulated experience of the systemic discrimination in the context of other systems of care. Why would we assume it's going to be different at hospice or in long-term care or palliative care or with a funeral home? Those accumulated experiences are always present in those interactions. And then, of course, those systems of care, hospice, palliative, funeral, they also have their own embedded forms of systemic discrimination. So finally, I just want to share, since it seems kind of negative, I want to share some opportunities for thought and for growth and for sort of positives. Even though we still have this primary composition of white middle-class women, there is much more diversity of those who are being trained as end-of-life doulas, including people in the LGBTQ plus community, people of color, other marginalized groups, as well as different faith communities and cultural backgrounds. So we are starting to see some of that shift take place. There's also much more training of mindful practices, being mindful of cultural competence, not only with these identity groups, but also faith-based and spiritual practices and cultural traditions. We're also starting to see sort of this opening of community care approaches that de-emphasize institutionalized settings and center conscious dying and access to support and care for those who don't have options. And again, care sort of outside of these institutionalized settings. We're also seeing a push toward queering the system. And what I mean by that, for those who might be unfamiliar with the concept, it's really a term borrowed from disability rights groups and civil rights groups who want to disrupt these systemic discrimination practices that are part of these larger institutions in society. And so really trying to think outside of that rather than work within the existing system by providing sliding scales, not seeking regulation or standardization of care, but sort of leaning into this wide variety of practice. Increasing access in rural communities, and those could be having centers for conscious living and dying, for instance, is one near me. Ensuring that folks have their identity and their wishes honored, not only during the dying process, but also through death and also post-death. And that, I may have rushed through as well with Marion. I wasn't keeping track of my time, but I am happy to entertain questions. This is my email address. If folks want to follow up with me, please do. I welcome continued conversation about this topic for sure.